Hello and welcome to Lunch Break with the Village. I am Yvette Young, Associate Vice President of Training and Advocacy here at the Village. We are so glad you could join us today. Please put in the chat where you're logging in from. We'd love to know. May is Mental Health Awareness Month, and so our focus today is on obsessive compulsive disorder. We really decided to hone in on this particular diagnosis because people feel that they have a good grasp or understanding of OCD, but a lot of times there's a lot of generalizations or stereotypical versions of what OCD is, whether it's something you've seen in a movie, a TV show, or you've heard people jokingly make comments about it. But we figured that it was really important for people to truly understand how this disorder present itself, the struggles that people who are diagnosed with OCD go through, so that we can normalize it and not have it be this, sort of created concept of what this illness is. So we're very fortunate today to have the opportunity to have join us and being able to share their expertise in this area. Dr. Laine Taylor, which is the village's chief medical officer, and Keith, who is a volunteer with the National Alliance on Mental Illness, which is NAMI, and it's NAMI, Connecticut. So thank you both so much for joining us. We're really thrilled that you're here with us this afternoon. Before we dive in to have our conversation, and a very important one at that, just want to let audience members know if you have a question you would like to ask our guests, please feel free to add that question in the chat. We'll do our best to get to as many questions as we can during the show. So with that said, I do not want to waste a minute because we all know 30 minutes will fly right on by. And this is too important of a topic that I don't want us to miss any key details or information. So just to make sure we're starting with a level playing field and everyone is on the same page, Dr. Taylor, I'm going to ask you to provide an overview of obsessive compulsive disorder for our audience who may not be as familiar with it.
Thanks, Yvette. Yes, absolutely. It's my pleasure. And it's my pleasure to be here to talk about this really important topic. So obsessive compulsive disorder actually has a very specific criteria that to be a clinical diagnosis. It is an experience in which there are recurrent and persistent thoughts, urges, or images that the individual cannot stop from having, and they're not wanted, and usually cause a great deal of anxiety for the individual. So I want to really highlight that most of the time we think about OCD as having thoughts that people have that are recurrent and come over and over again, but it also can be an urge, and it also can be just an image. And these are thoughts, urges, or images that they cannot control and that are really unwanted. So in response to the presence of those thoughts, urges, or images, individuals will often attempt to ignore or suppress or even do things in order to neutralize the thoughts, images, or urges. So this is where we get compulsions that come in. They might have a mental act, like a counting thing or a thing they might say, or they might say within their mind, or they might actually do some act in order to neutralize or stop the persistent urges, thoughts, or image. And this is driven in response to the obsessive thought, and oftentimes have very specific rules. In fact, they have to have specific rules in order to neutralize the thought, image, or urge. So the idea is reducing the stress so that they don't have to continue to deal with that image. But in response to that thought, they will the response or the neutralization doesn't necessarily have to be directly connected with whatever that obsessive thing is. It's just that it has to be done in order to neutralize, but it doesn't necessarily have to have some realistic or rational connection to the urge or the thought or the image. The other really important component is that it has to be time consuming. So this can't be something where like they might be worried about one thing and they will do this other thing in order to neutralize it. It has to take up time. An example could be that someone has an image of someone breaking into their home. And in order to neutralize this image and even prevent someone from actually breaking into their own home, they have to lock the door 8 times, but they have to do it in a very specific way, right? So we think locking the door 8 times, that shouldn't take too much time, right? Okay, 1, 2, 3, 4, 5, 6, 7, 8. No, It has to be done a very specific way if we're talking about a compulsion, so that if it is not done in that way, then they often will start all over again. So the actual disorder, it must take up at least an hour a day of your time in order to deal with the obsessive thought, image, or urge, and the action, if you have a compulsion, similarly must take up a great deal of time. And then finally, another important component is how well aware are these individuals of the fact that the thought, the obsession, or the compulsion is excessive, right? That speaks to level of insight. So do they have awareness that, yes, in fact, like, all factors of safety have been taken into consideration. They might actually have an alarm. They live in a safe neighborhood. The likelihood of somebody actually breaking into their home is pretty small, yet they still have this image that they cannot stop, and they still have the ritualistic behavior that they cannot help but do. They have awareness of the fact that this is excessive, and that is good or fair insight. Then other individuals say, well, it's very probable somebody might break into my home. I mean, it can happen. And it's also very probable that if I don't lock my door just right, then they very well might break into my home. That's when we talk about poor insight, right? That the thought is that if you do it 8 times and do it 8 times just right, then that's the thing that's going to stop this thing from happening. That's considered poor insight. Then it gets to the level of delusional beliefs, where actually then they're convinced, absolutely convinced, that this is true. And there's a departure from reality around realistic worries about safety, and the actions actually having some direct and real impact on their safety. So those are the criteria for obsessive compulsive disorder. The keys are: causes a great deal of distress for the individual, that they have to have the images, urges, or thoughts, and they have to they need to find some way to kind of neutralize it.
Excellent. Thank you so much for that. I think you answered the second question I have, which is how does it manifest in individuals? I think your example with the locking of the door is a really good one. Are there any other examples you want to share that gives people sort of a breadth of how it can range in folks that are diagnosed with this?
Yeah, I definitely can talk about that. I mean, I have a number of examples. One thing though, when you wrote that question, I was thinking about sort of how it can play up developmentally, right?
Okay.
And so something that's really important to think is that there's sort of onset is what we call bimodal, right? So it can have an onset in pre-adolescence, but also in 20s are the most common times in which OCD will appear in individuals. When we're talking about kids and how it appears in kids, typically it becomes a rigid adherence to a particular like routine or ritual. So, the kid needs to have, their teeth brushed, face washed, and shower in a very specific way. Well, a lot of kids are very adherent to routines. That doesn't necessarily mean that they're going to develop OCD. But the issue is the amount of distress of not doing it that way is
Mm-hmm.
the key, right? So that in these kids, when it doesn't get done just right, then there can be explosions, there can be behavioral outbursts. Similarly, there often is a lot of accommodation of the parents because the kids' anxiety about needing things to be done just so is so great that the parents do whatever they can to just kind of get through what they need to do, and in fact inadvertently encourages the ongoing behaviors. And so that's sort of how it tends to really manifest when you're younger. The other piece is that the fears are most commonly around safety when we're talking about kids. When we get to like the adolescence and the 20s, it gets into obsessive thoughts that are most common around ritual, religious, moral, or even sexual obsessive thoughts.
Excellent. Thank you for that. And I really also appreciated in your first response talking about that criteria and that level of disruption in your life, right? So you'll hear people go, oh, I have to, lock my door every night. I have to go and double check to make sure my door is locked because, I don't feel safe if it's not, or I had to go do this one thing. And they think that, oh, that must mean that I have OCD, when in reality is no, you're being extra cautious. But as you said, that criteria, that threshold is it has to be done in this very specific way and it could take multiple times before it's done right. And I think people tend to not get that piece of the equation. and assume because they have a repetitive maybe practice that they have that they do once or twice for like a minute or two, that automatically means that they have this disorder. So I really appreciated that clarity in your response. So let's talk about prevalence, Dr. Taylor. How prevalent is OCD in society, and are there certain demographics more affected by it?
Yeah, so it's 1 to 3% of a general population that has that over the lifetime has OCD. So this is usually about 2 to 3 million adults and 500,000 children in the United States that have OCD. Um, there have been a lot of studies to look at whether there is gender differences. Kind of it seems to come out a little bit in the wash. Women are definitely more diagnosed with OCD than men, marginally by 1.6% more common. But the literature seems to think that even though they get high rates of diagnosis, it doesn't necessarily reflect actual population prevalence, that it's likely more an access issue and more sort of how people are diagnosing as opposed to actual likelihood of OCD to occur in the
Okay.
population.
Thanks for that. Thanks for that perspective. So Keith, I'm going to come to you now. What are some of the challenges individuals with OCD face in their daily lives?
That's a great question. I think the biggest challenge, at least for me, can be that it's just very time consuming. These kind of intrusive, unwanted thoughts or the compulsive actions can, become so prevalent, especially if I'm kind of having a flare up in my OCD, that it just impacts the ability to enjoy things, to like enjoy time with friends and family, to work, really, and it becomes difficult to function and just kind of live a normal life because you're constantly being taken out of, you can't just, you know, just live. You're constantly being taken out of it by these unwanted thoughts that are entering your mind. So it's almost like you can't be fully present. Another challenge for me has been in the workplace. It can be difficult, again, if you're having a flare up in OCD or symptomatic, like um, it can sometimes present as, you know, um, this person is taking a lot of time doing these things. Is that are they really, it can be difficult to concentrate or focus on work, or they can it can just seem like it takes you longer to do tasks because you're dealing with this whole other thing at the same time. So those are just like a few of the challenges that people with OCD can face.
Thank you so much for being honest and vulnerable and sharing, your perspective and your story in regards to that. It does. If it goes back to what I said about Dr. Taylor saying it's ours. It's not just this little blip. And I want to start with you, Keith, for this next question. What are some of these misconceptions about OCD that you'd like to dispel, so that we can kind of get people to really truly understand how impactful this disorder is in someone's life?
Sure. One that I would like to dispel is that some people think of it as more of a personality trait. They're like, oh, like, I'm so OCD about that,
Mhm.
and it's really a serious, mental health condition that that again, is very can be very debilitating or difficult for the person dealing with it. So when someone says that, it can kind of be trivializing it. The other misconception I'd like to dispel is that I think when people think of OCD, they tend to only think of hand washing and contamination related
Mhm.
fears. And I think that's definitely a huge manifestation of OCD that a lot of people have, but there are a lot of different types of obsessions and compulsions that people have that don't always involve, there are people who could have OCD and they're like a fairly messy person. I know I'm not always like the neatest person. So because that's not necessarily what my obsessions are focused around. And then the other thing I do kind of want to add is that so there's something that some people call pure O. It's kind of a misnomer because if you have OCD, pure O means like it's all about the obsessions and not necessarily compulsions. But usually what that means is more that the compulsions aren't visible or obvious to
Mm.
people. So like for me, a compulsion might be like obsessive seeking reassurance. So like constantly asking somebody if I did the right thing or if I did this right. Or it could be something like obsessively Googling or researching things online, like, oh, like did I um did I again do I yeah, so those are just some examples of you might not think of that as necessarily like, okay, I have to lock the door 8 times. That's definitely a lot of people with OCD do experience compulsions like that, but it can also be things that are sometimes a little less obvious to people.
No, I really appreciate you sharing that because you're right. We don't see everything, right? And as I said, sometimes those misconceptions have come from TV shows or movies and what people want to dramatize. And so
Mhm.
we don't have a full breath because you're right. There are private things that folks do that will never be seen by a public eye unless you have a partner, a family member, someone
Mhm.
who's living with you and they're the eyewitness to it. So, Dr. Taylor, quickly, and then we have an audience question actually, which I'm going to throw back to you, Dr. Taylor, because it's a medical one. But what are some of the misconceptions you would like to dispel about OCD?
I think Keith said it well. I think, you know, your cousin who likes to have their house look a particular way and doesn't like dust and that kind of thing, you know, white gloving it, that does not mean OCD.
Mm-hmm.
I think one other piece that's really important to know is sort of typically it's characterized by two different ways, a sort of waxing and waning, or remission and remitting, um, um, remission and reoccurrence is that you can have some individuals have, like he said, I think, what was the term you said, Keith, was
Pure O.
no, the sort of like an episode or a period where you're
Oh yeah, like a flare up.
yeah,
Yeah.
a flare up,
Hmm.
thank you, where it can be that they have flare ups and then actually have periods in which individuals have they're symptom free. Other individuals live with it at a constant level, but symptoms are worse or better. But most people actually don't live their whole life with OCD that meets clinical threshold. Average length is about 8.9 years of lifetime prevalence, so lifetime experience with it. So people can get better. People do get better. It is, you know, I think it is a very serious, obviously, as Keith described, and can impact people on every aspect of their life. And so, if you do have concerns, I think it's incredibly important that you provide support to your loved one, and help them to get some help.
Excellent. That's going to be the next question after this question is how you support your family and friends. But this is an audience question. I think they might have meant induced by, but can a pregnancy induce an OCD issue that was manageable for several years before? So I think going back to Keith's point about flare-ups, right, and what you're saying, Dr. Taylor, about it can happen in pockets and periods over a period of time. But I think the question specifically is related to, can pregnancy cause or be a reason why someone flares?
Absolutely. That's a really excellent question. In fact, for women, that's one of the most common times in which either OCD emerges or it worsens. So in adolescence, and during periods of pregnancy. So that's actually an excellent question. Yes. The answer is yes. If you had OCD before, you have a higher likelihood of a flare up, as Keith called it. And if you didn't have it before, you have an emergence of symptoms, that's also a very high likelihood time for women.
And so, what would be your recommendation for women who are experiencing that during pregnancy?
First off, being pregnant is hard enough. So
Mm-hmm.
then to have to deal with, you know, such awful obsessions on top of it, absolutely go and seek treatment for this. It will make such a difference in your ability to really be present for your body at the time of pregnancy, and as well as being able to care for your child, because it can be overwhelming and overcoming for a great number of mothers who are trying very hard to be the best parent they can. So seek treatment. You can take medication while pregnant to address these symptoms and this disorder. So there are actual treatments that you can receive in order to feel better and go back into remission.
Okay. So since we're talking a little bit about treatment, Dr. Taylor, I'll skip around a little bit with the questions I had. Um, can you talk about any recent advancement in research or therapy for OCD that you find particularly promising?
Yeah. So there's kind of always something out there that's new and shiny around OCD, just to be honest, because it is such a distressing disorder that there are a lot of efforts to try to find something that will make it go away really rapidly and kind of magically almost. Again, the level of distress individuals with the OCD experience, it really bids for something that's going to treat this quickly. And the reality is that research really hasn't shown that anything can do something dramatically and quickly. It's the tried and true therapy of exposure response prevention and use of antidepressants such as SSRIs or SNRIs, meaning Prozac, Lexapro, fluvoxamine, or Effexor, Cymbalta, et cetera. Those are really the tried and true treatments that have demonstrated the greatest efficacy. There are some studies looking at things like deep brain stimulation, vagal nerve stimulation, and transcranial magnetic stimulation, but none of those longitudinally or long term have demonstrated effects greater than placebo thus far.
Okay, excellent. So the audience member had a follow-up question. Is this also a concern postpartum? So post,
Yeah,
it is as
yes,
well. Okay.
yeah, absolutely, and it's something I think within again psychiatry we consider that has a risk of becoming kind of a psychiatric emergency and needing to make sure that you really seek treatment.
Excellent. All right. So how, and this is for both of you, we'll start with Keith so Dr. Taylor can rest her vocals a little bit. How can friends and family members best support someone with who's been diagnosed with OCD?
That's a great question. So I've been very fortunate to have friends and family that are very supportive. I think for me, the biggest best thing you can do is kind of try to educate yourself about OCD and mental health conditions in general. I know, so I'm a volunteer for NAMI, which is the National Alliance on Mental Illness, and they offer a family to family course that a group that meets and where people who have family members who struggle with mental health conditions can meet and discuss. So that's definitely something I would recommend. I also think for me, it's kind of a mixture of it's kind of a fine line between being patient with the person's obsessions and compulsions, but also gently supporting them to seek treatment and try to move past it. I think the biggest thing is that it's not just a matter of willpower. It's not just something that the person can just stop doing, you know. It requires treatment and it requires help. So I think supporting the person to seek treatment, but you know, not getting exasperated and you know, yelling at them for something that they can't really control.
Valid point. Very good point. I mean, support is supposed to be kind, right? And I
Mhm.
think sometimes people miss that. They think that by yelling or screaming, it'll just go away and you just, need to get over it. And that's the worst kind of support anyone could give someone who's struggling. So kindness will always win at the end of the day. Dr. Taylor, anything you want to add about that? What else can folks do to support someone who is diagnosed?
No, I think Keith here spoke to it beautifully. I think it's really about meeting your level where they are, but I think it's important to not allow them just to continue to be in that space of the obsessive space, because it can get deeper and deeper, and they can be less and less able to live their life and be active in their life. So being able to help them understand that this is where they are and that they need support and they need help, treatment is really important.
Okay, and I think this next question sort of piggybacks on that. Like, what if someone, or what advice would you both give someone who suspects that so maybe like, let's say me, I'm thinking I might have OCD, or a loved one may have OCD. What advice would you give? What would you recommend that they do? Because there's a lot of people who, as I said, think they have OCD, but actually don't, right? Because they bought into this idea that because they do something repetitively or maybe because they obsessively shop or purchase things that falls under this category. So what advice would you give folks to make sure that they steer themselves or a loved one in the right direction? And Keith, I'll have you start.
That's a great question. I would definitely recommend finding a therapist or a medical provider that specializes in OCD and other anxiety conditions. I think even if the person doesn't have OCD, they may have a different anxiety disorder, or they may just have other issues that they want to work out with a therapist. So I think if that's something you can do, I think that I always recommend that to anyone. I think organizations like NAMI that also provide peer support can be very helpful. And I think the biggest thing I would say to someone is just that if you're experiencing those types of symptoms, that it can get better, that it's not going to be forever, that there is help out there. So that's what I would tell them.
Excellent, Dr. Taylor.
No, beautifully put, Keith. Really beautifully put.
All right, so my closing question, because we're just a few minutes out from the end of the episode, is and I'll ask this to both of you because we want to end on like a light, uplifting note. Is there a message of hope or encouragement you'd like to share with those who are struggling with OCD? So if we have folks listening in or listening at some future date, what do you want to say to them to encourage them about what it means to be a survivor and to get through life with this diagnosis? Dr. Taylor,
Sure.
we'll start with you.
I think, the reality is you can feel better with this disorder. You can be in a place where you can live a happy, productive life, where you have positive relationships. I think that, to expect you can do it on your own, or you need to kind of white knuckle it or tough it out or just push through is an unreasonable expectation of yourself. Getting support, doing the right treatments that help you systematically learn how to deal with and reduce and remove the obsessive thoughts and the compulsive behaviors that impact your life so greatly. That's an imperative piece of it. And don't be scared of the medications. The studies have shown that the medications, along with the therapy, demonstrate more full and more rapid remission of symptoms. This is an anxiety disorder, and it causes folks to want to kind of avoid and remove themselves from life because it's so overwhelming. And you have partners out there. There are people who can help you both clinically as well as other individuals with lived experience. You're not alone. Please reach out.
Thank you so much for that, Keith.
Yeah, I think Dr. Taylor said it great. The only thing I would add is that I think ERP, exposure response prevention, which is kind of the recommended sort of gold standard treatment for OCD, it can be really tough. And I think it's important to look at treating yourself holistically. But what I mean by that is, yes, the medication, yes, therapy, but also looking at are you having enough social engagements in your life? Are you are you seeing family and friends? Because I think sometimes it can be so easy to retreat into OCD, into the obsessions. And I think when you're working on something um and doing the best you can to kind of get out of it, it helps to have something else that you can either just kind of distract yourself with a little bit, um or other things going on in your life that you can feel excited about. So yeah, that's the only thing I would add. And there's help out there. So
Excellent. I want to thank you both so very much for joining us today and for sharing your wealth of insight and knowledge with us, and Keith for sharing your personal story and journey with us. I just want to also let the audience members know the Village is here for you. We're a nonprofit behavioral health organization. This is our area of expertise, is mental health treatment. And so if you do find yourself struggling or a loved one struggling, reach out to us. Give us a call. We have our UCC Center for walk-ins for our adolescent age kids. We have outpatient services, in-home services. So we really run with prevention services, school-based services, residential care. So we do provide a continuum of care here at the Village. So if you need us, reach out to us. There's no shame, there's no stigma. No one's going to judge you. All we want to do is be able to support and help you. So you don't have to live with and be in pain and suffer. There are resources out here to help you. So, this Mental Health Awareness Month, I hope that's the message. That is a takeaway, is that seek the help and support you need. If you can't find it within your family system or maybe even within your friendship group, know that there are professionals out there that will provide you with the support and care that you need. So make sure you extend that reach beyond those networks of people if needed. So with that said, we are at the end of the episode, and I just want to let folks know our next episode of Lunch Break will be in June, and it will be on a new, innovative, cool sort of walk-in pod clinic situation that we have called OnMed here at our Village South Weathersfield Avenue site, where you can go in and get triaged for any medical issues that you might be having. And it's an amazing system. Hartford Healthcare and OnMed has brought that into the community, allow for more easy access to like medical urgent care needs in communities. And we're going to have a conversation with some of the folks that are tied to that particular initiative in June. So please join us for that episode. As always, if you want more information about Lunch Break with the Village, you can reach us on LinkedIn, on Instagram, Facebook. We have a landing page on the Village's website. You can check out previous episodes that we've done. So please reach out. You can find out about upcoming episodes as well. So as always, thank you so much for joining us and being here with us. We appreciate you. We value your support. And until next time, be well.